Well, welcome everybody to our first CC event of the new academic year. We're very excited to see you all here. There are so many of you here. It's a wonderful opportunity. We want to thank our co-sponsor, the University's College of Osteopathic Medicine. Thank you all. And I also want to say that this production was part of an amazing team co-designing this for you today. And thank you to everyone. You will meet them all. So acknowledge yourselves in your breakout rooms and during your session. Today's event is to really look at childhood obesity. And childhood obesity is a very misunderstood and often highly misjudged medical condition. And we have a team today, Dr. Valerie O'Hara leading the team and it takes a team to work with childhood obesity. So we're very pleased today that you'll be learning with and from that team about the medical, psychological, social issues that affect families and children with childhood obesity. So my job now is to turn this over to Jen Van Dusen. And Jen, I'm going to introduce you. So you ready? So it's absolutely my pleasure to introduce Jen Van Dusen. She's a longtime friend and colleague, and you've been an ally of interprofessional work from the very beginning. So we really thank you for that. We'll miss you so much as you move into retirement. Although for those of you who might not know Jen, she is not a retiring person at all. And we wish you well in everything you do. In your career, you are an inventive and transformational educator. You hold degrees from Lesley, Goddard, and Southern Maine universities. Pretty impressive. You're currently the Director of Curriculum and Interprofessional Lead at Unicom and the PI on the Providers Clinical Support System SAMHSA grant. And that you're also, I told you she wasn't retiring, you're also the Executive Director for the Coalition on Physician Education and SUDs. I also almost made you a physical educator. When Jen's not working, which is kind of a mystery when that actually happens, she is gardening, traveling, reading, experimenting with technology, and listening to music from the 60s, which I totally appreciate. So thank you so much, Jen, for everything. And you can take it from here.
Thank you, Shelley. I did not expect that lovely intro. That was really fantastic. Thank you so much. And welcome everyone to our session on exploring childhood obesity. It's a really important topic that we're going to be exploring today. And I'm so happy to see so many students here today. I want to ask all of you students, if you have not already, to please put your name and your health profession in the chat. And I'm very excited and delighted to introduce you to our pediatric obesity medicine clinical team, starting with Dr. O'Hara and her colleague, Ms. Johnson, and their colleague, Dr. Curran, who you'll be hearing a great deal from today. So I am very excited, and it's a pleasure to be with you all, especially since we are joined by a robust number of other professions, leaders in the other professions. These faculty members will be are joining us. They've helped participate in developing this session, and they will be facilitating breakout rooms and otherwise offering pearls to students on their topic. So thank you all for all of this getting together. To kick this off, we'd like to activate everybody's brain. So please log into Poll Everywhere, as you can see right there at the top. And we would very much like to have you tell us what your thoughts are about children with obesity. When you think about that, what comes to your mind? What is one word or two or more words with an underscore between them that will let us know really what your thoughts are, what you're showing up with today? Wow, look at that right in the center. Look at that, it makes almost a sentence. Poor nutrition, lack of nutrition, bullying. These are big words. These are big concepts that are impacting our children in their early developmental and foundational growth times in their lives. Diabetes, socioeconomic. Wow, look at these. Some of these are almost social determinants of health, lack of education, poverty. Oh, all of these challenges, body shaming. I see McDonald's. Um, wow, this is a fantastic insight for us as we begin to approach this from an interprofessional view and look at all of these things that you already know. So we are hoping our plan is our intentions, let's not make it a hope. Our intentions are that you come away today with a deeper understanding of the complexity of this issue and are even more aware of the stigma attached to this disease. And as we saw in that word cloud, many of you are already very much aware of that. We would like to set you on fire in your future profession about working with children with this chronic disease. And when you leave today, that you demonstrate a knowledge of your role as a professional in this care team and an understanding of the others on the team that you will be working with in your future. The IPEC competencies today that we are focused on are ethics and values and roles and responsibilities. So that is our intent. And we are going to turn this right over to Dr. O'Hara and her team. And I believe we were going to jump out of the slides with this so the team could introduce themselves. So Dr. O'Hara, you're on.
Thank you, Jen, and everyone on the CC team that has worked with us. This is a very new model for myself and my team, but we're super excited and we thank you for this opportunity to share our passion and our experiences around pediatric obesity and also to learn from all of you today as we go through this learning experience. And it's very fitting that we're doing this in September, which is National Childhood Obesity Awareness Month. And I would agree and echo what you said, Jen, the vibrance of the response in the word cloud and all of the different views is so exciting to see. And I'm looking forward to the conversation. I am also here with Star Johnston, who's our pediatric nurse clinical coordinator. So I don't know if you want to say a few words, Star.
You need to unmute, Star.
I'm sorry. I've been doing this for 15 years with childhood obesity. And today I'm going to talk about my role as the first contact with patients and families.
Thank you. And Dr. Jen Curran.
Good morning, everyone. I am a pediatric psychologist, and for those of you that may not know, what that means is I'm a child clinical psychologist, and I have done my clinical training in a medical setting. Most commonly, it's a children's hospital. And in that training, then we identify areas of specialty that we focus in. Some folks, it's endocrinology, some it's GI, some it's sleep medicine. And for me, it was pediatric obesity medicine. In my role here, what I do is I meet with all of the kids coming through the clinic and talk with them about what's happening in their lives, what's happening in school, what's happening with friends. We identify concerns. we think about what needs the family has, what needs the child has, and we come up with a plan. And we say, hey, here are some things that might be great to think about and to work on moving forward. And then I intermittently meet with families over time. So I get a chance to assess, how are things going? Is there any other ways that I can be helpful? And so that's my predominant role in the team.
Great.
Thank you.
Thank you, Jen. And another very important member of our team who's not with us today, she was unable to join. And I see many of the students are in this area profession as our dietitian. And she works with us very collaboratively to do a lot of what Dr. Curran said, assess where the patients are, understand their nuances, but also helping us as a team to provide precision type medicine that will really, really target what's going on for the patient with obesity and the related comorbidities that we're oftentimes managing across the whole team. And then coming back together, all of our thoughts and ideas and discussion with the family, we come up with a very good treatment plan that is hopefully going to improve the overall health of our patients.
Welcome, team. This is fantastic. So you folks are on. We're going to learn some things from this team to get us started today.
Great, thanks. So we're going to start off with a very basic definition of childhood obesity, and we'll talk a little bit later throughout our discussion today and get in a little more detail. But as a basic BMI growth curve, the CDC has those curves out there, and a child whose BMI is at the 85th percentile or above, as you see on the left, would be classified as overweight or obesity. In 2016, we reassessed this BMI curve to expand that. Oftentimes because many of our patients with class 2 and class 3 obesity using the prior growth curve did not have a line. We could not monitor progress quantitatively. So we developed class 1, 2, and 3, really mirroring the adult nomenclature that exists to better define obesity in respectful ways rather than negative connotations that oftentimes might have been related with prior terminology such as morbid obesity. That doesn't help us or our patient. But having these classifications allows tracking. It also allows us to assess risk. We know risk of other comorbidities and disease process goes up as BMI classification goes up, and it also helps guide our treatment. And right now we know that roughly 4% and 9% of children and adolescents are now falling into class 2 and class 3. That is the fastest growing subgroup of pediatric obesity. And you can see there on the slide the prevalence. Over 340 million children between the ages of 5 and 19 have overweight or obesity as of 2016. So this really prompts our passion to be here with you all and to move forward to better providing care for our patients.
I'm up next talking about barriers to treatment of childhood obesity. We can't talk about the treatment without talking about barriers because it's pervasive in what we do. And there's a reason that bias and stigma is listed first here. And that's because it colors all of the other pieces that we're going to be discussing. So we're going to focus our discussion today on pediatric obesity as any other disease, not by any kind of cultural definition. That's what Dr. O'Hare was just defining for us. And with any disease that's been stigmatized, there's shame, there's blame associated with the struggles, and it's seen as characterological rather than a disease process that needs to be discussed. And so we're going to focus on pathophysiology. We're going to talk about co-occurring concerns that impact care and that we address in our intervention. And we're going to think about the effective treatments. And if a treatment isn't working, then it's not a matter of failure on the patient. It's a matter of needing to find a different intervention that's going to be effective. When you talk to patients, their lived experience and what they ask of us is, if you give advice, make sure it's accurate, it comes from the heart, and it reflects the complexity of the disease. So that's really what, the overarching, when I think about barriers to care, it impacts implementation of standardized screening guidelines. It impacts education that's offered. It impacts access to care. So there are very few obesity medicine specialty centers. They can be hard to come by. A lot of the children's hospitals will have them, but in rural areas, it's increasingly a struggle to identify service and care. Coverage is limited in terms of reimbursement. Medicines aren't covered. There are certain criteria that need to be met in order to receive care. And then we're talking about there being greater risk for certain populations. And that has to do with some of the things that came up in the initial poll, right? So socioeconomic status, we're talking about intergenerational trauma. We're talking about lots of things that are going to impact the risk of someone developing childhood obesity.
Hi, everybody. I'm back. We really thought that the best way to really think this through for you is to have a case where we are going to introduce you to a person we have called Sarah. And I want to thank Shelley for reminding us that the patient and their family are key members to the interprofessional care team. So we'd like to introduce you to Sarah. There's a picture of her. And Sarah is a 17-year-old cisgender girl, and her family of 5 have just recently moved to a much more rural town than she was in before, where she's now attending the local high school as a junior. She loves animals, especially dogs and horses. Sarah eats 3 meals and several snacks a day. She describes being hungry all the time and says that she's never really felt full. Her mother admits to being frustrated by her daughter's constant appetite. During the week, Sarah, like many teens, spends lots of her free time using a screen. She's on her computer, she's on her iPad, she's on her phone. Her previous primary care physician observed that she was, quote, obese, but a really sweet kid. Sarah is set for an annual physical with a new primary care provider since she's now moved, and has asked that her mother go with her. Prior to the visit, your team, which is part of that new primary care situation, reviews her records. And here's what the records indicate from over time from her previous healthcare facility. She has moderate intellectual disability. She has mild sleep apnea. She has hypothyroidism. She's been diagnosed with obesity, beginning when she was about 5 years old. She has compulsive eating patterns and loss of control over her eating. Dr. O'Hara, do you want to include any additional facts about Sarah before we move on?
I think this is great. I think this is a great place to start. I think given the word cloud and some key points in this history, really should be sending up red flags to all of us about what sort of care Sarah will need. I think it touches on bias and stigma in the words we use when we're engaging with our patients, particularly, and her journey. She initially came to us when she was around 7 or 8, but she was lost to follow-up because of a loss of insurance. And then when she came back to us 6, 7 years later with a worsening of her BMI up to class 3. So I want you to be thinking about what the behaviors are that we're seeing described here, but what might be the pathophysiology or what might be driving what we see as behaviors. So really thinking deep about those thoughts when you move into your breakout.
Excellent, thank you. Nice segue. There's a little foreshadowing. We are going to put you into some small groups for team building now, where we will put the case write-up in the chat so that, and which will be available to you in the breakout rooms, so that you'll be able to refer back to that and with these directions as well. What we would like to have happen in this room, in these rooms, is there should be a facilitator in your room. If there's not, please choose someone who's willing to make sure everybody has a chance to talk and can move the conversation along. We're going to ask you also to volunteer a scribe to capture the discussion so that they can then paste the takeaways from your group into the chat when we come back to the big group. Here are the questions or things we'd like you to contemplate together as an interprofessional team. First of all, so that you can know who's in your team, we'd like you to please introduce yourselves briefly with your name and your health profession, and potentially, if you have time, with scope of practice with children and families. And then, what are your assumptions or your experiences relating to obesity in a young person? Are there any questions about the team building session? Check in the chat. Okay, seeing none, we'll see you in approximately 10 minutes. And we hope that you have a very fruitful opportunity.
I would say what stood out for our team initially, if we're going to sort of just get the ball rolling as things appear in the chat, is really all of the students were very much aware of the need of the complexity and really the need of working as a team and sharing that interdisciplinary team, and some great points around location, rural, recent stressors of a move. So all of those really great discussions across the team that was in our breakout room. Great conversation.
Great comment. Ours, in room 4, we kind of shared the whole idea about, it sounded like making sure that the young person has some agency in deciding what kind of activities they're engaged in, and to also really look at the social determinants of health. And an assumption that came up was, it seems like potentially our assumptions might be that if a person has obesity, they might be in the lower socioeconomic stratum, which, and then perhaps there could be some things to be done about that. Seeing all kinds of great stuff coming into the chat here. Wow, yeah, with all genetic factors, health conditions, there's socioeconomic again. Low-income families tend to lean towards cheaper foods in bigger quantities. This is all very, very interesting. Look at all these others. The comment of obese but a sweet kid was interesting, as if being obese is mutually exclusive from being a sweet kid. There's some of the bias and stigma raising its head already. I think we are ready for some more discussion, unless there's any quick last word from another room. We're going to turn it back over. Anybody feel something pressing they need to say before we move on? Okay, let's see. Dr. Curran, I believe you are on now. Whoops, we just did the debriefing, so we're good with that. Curran, you're on.
Okay, thank you. So more thoughts about bias and stigma and how it impacts, obesity over the lifespan. So our focus is on childhood and adolescence. And in early childhood, what we see is negative weight stereotypes beginning in preschool, thinking about kids not being involved in certain activities, not being included in certain activities, not feeling comfortable joining different types of community programming, things like that. Over time, stereotypes worsen, leading to teasing and bullying. So now we have sort of this active cruelty that kids are facing when they go to school, when they're talking to their peers. And it might not be just sort of not being chosen, but it might be active sort of in this negative process. In adolescence, continued bullying across sources. Now we're talking about increasing anxiety. I might not want to go to school. I might not feel comfortable being parts of things. I might not feel comfortable introducing myself to someone or talking to someone. And now and also impacting physical well-being. So it might be adding to chronic stress and just general sense of unwellness. As we're getting older, then we're talking about weight bias institutionalized as discrimination when it comes to employment, healthcare, education, and then that continuing over the lifespan.
Absolutely. And I think as Dr. Curran's talking, and we think back to Sarah specifically, she's had a recent move. She's lost some of maybe her best friends. She's in a new environment. And think about chronic stress, the impact on our emotional well-being, but we also know that chronic stress has a metabolic impact. So we have to be thinking about how that may be increasing one's risk of obesity as well as other obesity-driven diagnoses such as diabetes and hyperlipidemia and all those sorts of things. So we need to be thinking about how that impacts the patient and the family. What is the dynamic there between mom and child and comfort level? And oftentimes, as Dr. Curran's talking, and this is a slide from Dr. Rebecca Poole's work, sometimes patients even within a family are being bullied by family members or teachers or healthcare providers. So really having an awareness that is there and that your patient has likely already encountered that in their lifetime, even as very young children. So I was able to work with Dr. Poole and others on a paper that was published in the Journal of Obesity in 2021 that really tried to break this down into subsets in terms of barriers to pediatric obesity care. And you can see here, it's purposefully a wheel because all of these variables are interdependent upon each other to do really well. If we're going to be changing the outcomes for children who struggle with the disease of obesity, we need to be looking at this holistically. So clinically, we're talking about a case. We're learning about pharmacotherapy and options for patients. We talked about access. I think Dr. Curran mentioned it earlier, access to experts in the field, but also preparing our future providers to feel better able to manage our patients. And we're talking about education, addressing attitudes, bias. We're here today talking and really helping to pull ourselves out of our own silos to really work together will really ultimately improve the care that we give. And when we do this, we have a much stronger voice together in advocacy around policy and coverage of care and equitable care, regardless if this child is living in a rural part of Maine or in the middle of a city. If they have financial constraints, we need to really be thinking about equity for our patients. Touching a little bit on the medical side, and I won't get into all of this, but I think this picture really illustrates the complexity of obesity. There's not an unaffected body system when we think about obesity and obesity-driven disorders. This is something that we know many of our children, as we start to think about screening of our patients, asking those questions, really trying to consider all of the factors that might be happening for our patients that are driven by obesity and co-occur with obesity. They may include anxiety, depression, as Dr. Curran says, and we rely on Dr. Curran a lot in our clinic to help us with that, but also ADHD, the obvious prediabetes, diabetes, hyperlipidemia, obstructive sleep apnea, and how those all play together. And as professionals, we can say this feels overwhelming, and we're super excited that we get to work with our colleagues to help us better manage, and we do collaborate with our pediatric subspecialists. But now imagine if we take a step back, how a patient's feeling or a parent's feeling when these things are going on for their child. And these happen very early. 30 years ago, when I started pediatrics, many of these diseases were adult diseases. I'm like, oh, I don't have to worry too much about that. I'm doing kids. But we now are seeing these happening earlier and earlier in the process. And we do have an abundant amount of research to show that the earlier we intervene to treat obesity, the likelihood of reversing or preventing these secondary diseases is really important, and ultimately improving the overall quality of our patients. Next slide. So we started off with a very simplistic definition of obesity by looking at a growth curve. And pediatricians, we love our growth curves for sure. But I think obesity, as described by the Rudd Center, shares that it's a very heterogeneous disease which presents across the lifespan, including infancy. So this is oftentimes a conversation when I've worked with adult obesity colleagues where they're not always aware that this happens very early for many of our patients. And it negates the idea that this is a slow progression once someone hits middle age and they're gaining 5 or 6 pounds. This oftentimes will present very early in our patients. Obesity is a chronic, relapsing, multifactorial neurobehavioral disease, a disease that is caused by a complex interplay of genetics, epigenetics, social determinants of health, environment, family history. All of these things, over 230 diseases have been shown to be impacted by obesity. 13 of those are cancer by the OMA's definition. And Dr. Lee Kaplan, who is an obesity specialist at Harvard and Mass General and runs the Blackburn course, his statement is this: the final common pathway of all obesity is internal to the body and reflects disrupted physiology. And if we can start there as healthcare professionals with our family, that in and of itself, that obesity is a chronic disease, takes away their bias and blame. Because our job is to say, we're going to help manage this disease and explain what we see as behaviors. But if we can start to explain it physiologically and show that we have tools, we can go a long way in diminishing that internalized bias that many of our patients and families have.
We're going to shift gears here for just a moment and talk about the approach. What do we see in practice? We're going to talk about the patient's view and perspective and how we as a team support them. So things to consider when you're first making contact with patients is you may come across some patients and families while in a visit of another nature, or maybe they are there to seek help for the disease of obesity. So you want to remember that these parents are bringing you their most valuable, precious gift. So there's going to be a lot of emotions involved during this visit. There's going to be scared, self-blame, frustrated, vulnerable, as well as some are excited and hopeful and look forward to having their high expectations met. So we want to listen and validate that listening. So in the form of body language, you're assessing each other, make good eye contact, use welcoming language, and you can gauge readiness for treatment. And don't be hesitant to approach this as any other disease, because that's what it is. It is a disease, and the patient and parent may not know how to talk about it, and you can just ask, what would you like to call this? Avoid blaming. There's bias involved here, sometimes in the form of just the disease itself being ignored. And know that they've already tried things. They've already tried diet and exercise, low fat, low carb, the whole gamut. So you can tell them this is hard to hear. This is hard to understand, this disease process. And just, I wouldn't be doing my best if we didn't address it. And you can tell when somebody's like anxious or they're embarrassed or they're just off. And it's okay. Just say, thanks for sharing. I'm really sorry you're dealing with this right now. And validate their feelings and concerns and get comfortable. So the why, we know we're doing this because the diagnosis of obesity, especially in children, is placing a significant threat on short and long-term health. So we work together as a team. We support each other. We have all sorts of available tools. And we give the families a better understanding of that disease process. So parents may think that they're coming from medical care of obesity includes, oh, my child's got to be active, They got to eat healthy. Maybe they've been told, oh, they're going to grow into themselves. They may tell you that they're bullied. The whole family is big. We have no support. We're embarrassed. But take an important cue and just repeat it back. And that lets your families know that you've listened and this is a safe environment for you to engage and start treatment. And then you get to do what you're trained to do. You get to provide the medical care, you engage the patient and families, you learn from them, support them, and most importantly, you're listening and you're validating.
So what care do we provide? You've heard the different roles that we serve in a team. This diagram shows sort of a hierarchical approach, right? Where at the bottom, you're talking about self-directed change, things that families and patients may be doing on their own. It might be information they've received from the PCP's office. And historically, what has happened is then that has led to maybe, a couple of times meeting with the PCP and trying to make some changes, and then maybe being referred to an individual dietitian, and then sort of failing, I say, at each level, right? That the patient feels that way. They failed at each level. And so now they have to be assigned or referred to an obesity medicine center. That is changing. There's a movement for there being the severity of disease dictating the starting point when it comes to intervention. And Dr. O'Hara is going to speak a little bit more to that. But rather than this sort of like you haven't met, the goal, and so now you're being increasingly referred, it's, hey, this is a disease process. We see where you are in this disease process, and we're going to meet your need. And then we're going to refer you to the right folks. This professionally directed lifestyle change, blue sort of bar here, that's a really short nomenclature for lots of stuff that's happening. We're talking about sleep, and we're talking about routines, and we're talking about what happens after school, and we're talking about anything you can think of. There's a lot there. I'm going to sort of direct this over to Dr. O'Hara so she can speak a little bit about pharmacotherapy and some other comments that she has.
Sure. Dr. Curran, thank you. And I think you made some really key points when patients feel that they have failed. And as part of other lectures, we've oftentimes gotten feedback from participants via the chat that, well, I'm not going to escalate the level of care because I don't know that the family has tried hard enough. I don't think we approach any other disease like that, and we shouldn't. Right. So I think looking at the severity of disease, where now we have a much more respectful and accurate way of tracking and classifying obesity, the new guidelines that are coming out from the American Academy of Pediatrics this fall is removing the sort of timeline. You must do this for 3 months. You must do this for 6 months before we think about X, Y, or Z treatments. What we know now with 15 or 20 plus years of really in pediatrics focusing on understanding obesity, talking about it, and learning new tools, we've realized that it really is exactly as Dr. Curran said. If you have asthma and you are presented to the ER with status asthmaticus, we're going to elevate our intervention based on the patient's disease severity. And that is still what's going to happen in the new guidelines. It's sort of more circular as versus stacked up in this manner. So we're going to be able to move across the team from primary care to specialists to our colleagues within that interdisciplinary team to use pharmacotherapy and weight loss surgery and post-surgical pharmacotherapy as well to meet the need of the patient. And when we take away the blame of the patient who says, I've failed, we say, the disease that you have is requiring more intensive care. And if something is not working, we put our heads together and say, all right, what else is going on? What are our tools? And let's have a conversation with the parent and the child and talk about what those are and provide evidence-based care, as Star said. That is our job. And we want to give agency to the patient. We have to respect that. And we also have to take away blame, because many times our patients will say, well, Susie does the same thing as my son Johnny, and one of them has obesity and one does not. We have to understand the uniqueness of each individual patient. And it is not as straightforward. And I think some people in our breakout said this is very complicated and requires an interdisciplinary team. So we have foundation of intensive lifestyle therapy, but then we also have to think about the tools that are available to meet the severity of the disease for our patient. So this slide, I think, touches on some of this as well, the children who need treatment, and there's lots of promise. If we look back, there's a timeline here as well as a percent change in the obesity status. And you can see at the very bottom, intensive lifestyle therapy has been sort of the standard of care for a long time. We didn't have a lot of other tools, particularly in pediatrics, until we had well-designed studies in pharmacotherapy and metabolic bariatric surgery for children. We wanted to be very cautious, obviously, but we see from 2000 to 2022, we've learned a lot about the disease of obesity, and to endorse treatments that are limited to the mindset of the 1990s or 20 is remiss of us. So we do have a lot more tools that are available, and in a stepwise manner, assessing the severity, we can use those. And now we actually have a number of FDA-approved medications, just recently a GLP-1 agonist, Saxenda and Casimia, and well-done trials for kids, and newer combinations that are now available for adults that really is approaching metabolic bariatric surgery response. And these medications and treatments are really tackling the physiology around obesity, which becomes a very physiological mechanism of treating the disease. So I think we can learn from our past. We've learned a lot from patients who have undergone metabolic bariatric surgery, which has been informing our pharmacotherapy colleagues in research. And ultimately, this provides a lot of promise. And when we can share that with our patients, wow, they are excited to learn and are oftentimes the first time they're learning of that. So again, the importance of our education here today with one another.
Thank you so much. Wow, we have a lot more information about the treatment modalities available now. And I'm not going to read through all of this. I think all of you can read. And just note that we are continuing the case to really recognize that Sarah's mother is becoming aware of how difficult it is for them to buy healthy foods, and the family history has been integrated into the team's contemplation, so that we see there's obesity, hypertension, depression, and fibromyalgia in the family. You can see a little bit more about what happens to Sarah while she's at school. She has, since she does have that mild cognitive disability, she received some special education, and she's continued being bullied and teased even in the new school. So she appears to be less active than even more than she was, and she has some daytime. She has daytime fatigue, so she comes home very tired and doesn't necessarily want to get up and go to school the next day. So we're going to ask you to go back into your groups and to talk about what you've learned today thus far from the panel. If you can, to focus on what each of the presenters said about their role in this team-based care. So we're going to ask you again, please have your scribe ready, and to talk about how your team might address Sarah's obesity diagnosis with her and her family. What questions might you have for them? Think about what you're learning from each other, and how would you capitalize on each other's knowledge? I realize some of you need to leave at 1 o'clock, so if you can participate for a few minutes, that would be great. Thank you. We'll see you on the other side.
Turn it back over to Jen Van Dusen.
Wow, we just had a really great meeting in my group. It was really phenomenal. The biggest takeaways was from a faculty member from Salem State who is in the OT program. She's an occupational therapist, And she brought up the fact that she was kind of surprised that in the discussion, oh, I hope people of our scribes are dropping things into the chat while I'm talking. That she was surprised that there wasn't more of a focus on the strengths, Sarah's strengths and the strengths of her family. So that could be really built upon. And so most of us had a bit of an epiphany right there, and are recommending that as we begin to look at people with chronic disease, particularly this one, that we make sure that we engage people with lived experience. Not
excellent point. Our team kind of touched on that too, Jen, in that one of our medical students said, I want to approach this from what are her successes, small goals, obtainable goals, in providing resources and support. In this particular patient, she has a lot of strengths, and I know Dr. Curran and Starr can talk about, with an incredibly supportive family, a mother who had her own lived experience, having undergone metabolic bariatric surgery, what her wishes are for her child, the support of her teachers, a great school, new school of providers who were super helpful to her love of her horses, and she oftentimes would share, I can go and I'm teaching other kids how to ride the horse. I'm super good at it. Those are such positive affirmations that we got to hear from this patient. And I'm so glad that your team really touched on that, Jen.
We do have a hand raised. I'm not sure how to pronounce the. Oh, they're gone. Sorry.
I would like to hear from some of our other panel members, what their groups had to say, and or, our faculty members. So someone could just sort of blurt out, that would be great. If you could talk a little bit about what was happening in your room. If no one blurts out, I'm going to pick on some people.
We spoke about how she was feeling fatigued over the course of the day. And in the course of further evaluation, when we identified a mild intellectual disability and spoke with the school about her services, we also identified ADHD, and she began treatment for that and had much, I would say, more resources by the end of the day. She was feeling like she was meeting the needs of school. She was feeling like she was able to accomplish what she had to in terms of her assignments. The other thing that ended up happening was she joined unified basketball for a period of time and got a sense of belonging in that setting that I think hadn't happened prior to that in a sports environment. She had a coach that really just thought super highly of her and always included her in a way that brought her a sense of belonging. So those are some ideas that came up in our group and thoughts.
As you're talking, Dr. Curran, one of the points about her fatigue came up in ours too, from a medical perspective, is, she has mild obstructive sleep apnea. In the move, did they lose treatment? Has it worsened as her BMI has escalated? Do we need to repeat that? We know obesity and co-occurring obstructive sleep apnea can worsen attention, can worsen school function, but also can worsen obesity. So making sure that she had all of the tools that she needs to treat her already diagnosed conditions. Jen.
I am curious, Dr. Winston, Chris Winston, would you share a little bit, since the group that I was in focused on occupational therapy? Could you talk a little about what happened in your group? Put you on the spot here.
Yeah, we talked a little bit just about how we had nursing and dietary and OT in our group, and just how our various professions might interface with this, with Sarah and her family at certainly different points in her life and in different settings. And we talked a little bit about how her diagnosis and her being on an IEP would interface with her diagnosis of obesity, and how to really look at both the intellectual disability and how she comes to understand the other diagnoses. So that was a big piece of our conversation.
Excellent, thank you. And for a last word, and this for now, we've got just amazing stuff in this chat. I hope you're all kind of reading while we're also talking with you out loud. Would one of our pharmacy faculties, Dr. Allen or Dr. Dornblaser, can you share what happened in your group? Because we did close that last session out with discussing new medications. Either one of you willing? Are you still here? They maybe needed to go.
Well, I think in terms of pharmacology, there was a really interesting question about, do we know the long-term effects of some of these medications? Because they're starting medications very early in life. And Dr. O'Hara, you're nodding your head. So I think you know the answer, at least the speculations about those questions.
Certainly. I think particularly now that we have a number of FDA approved medications, and one of which is a combination medication, we feel a lot more comfortable using them with well done studies. Again, we have to also be thinking about, in terms of pediatrics and the paucity of well-controlled studies in that population. Many times in pediatrics, we do use medications off-label, and the American Academy of Pediatrics has a position statement on that. But certainly when we have really well done studies, not just in this country, but globally, we know that requires due diligence with any other disease. Many diseases that we treat are using medications that have pros and cons, and that's the informed consent and discussion that you have with your patients. And we know the long-term effects of untreated obesity warrant those conversations. And we do see the efficacy and outcomes for our patients when we are implementing medications earlier rather than later, because it is so progressive, and certainly trying to change a trajectory of a child who maybe at 12 was at the 120th. And if we do nothing until they're 19 and they're at the greater than 200th percentile, really reversing course becomes very, very difficult, with much poorer outcomes across all of these correlated diagnoses for sure. But it does require due diligence. We have to be well trained in the use of pharmacotherapy, using our pharmacy colleagues, also considering, which is, I was hoping the pharmacy people would be there, and they weren't in my group, but looking at weight promoting medications and what can we change, because sometimes those are additive problems for our patients. Again, patients are blaming themselves, but if they're on a medication that's causing worsening of their obesity or causing it in the first place, we really need to work with our colleagues to find alternatives and to be aware that some of these medications can actually be weight promoting as side effects. So great question, Shalini.
That's a great point, Valerie. In fact, insulin and medicines to help control the blood sugar a lot of times will stimulate the weight. So we end up fighting this vicious cycle in diabetes treatment until these newer medicines came along.
Yeah, absolutely. GLP-1s are great because they're going to treat your diabetes and treat obesity with a really, really good safety profile overall, and very few contraindications for sure. Great point.
And you also see kids who are struggling with depression and or anxiety related to the weight issues and the social impacts of those. And of course, those medications are all often weight producing. Sorry, Jen, for interrupting.
Oh, that's okay. I'm just want us to enable students to ask questions so that we have enough time at the end to have that. So I'd like to turn this over for a quick wrap up from Dr. O'Hara and her team. On slide 28, there we go.
Great. Awesome. I think we touched, we touched a lot on what Sarah's progress in her obesity treatment has been. I think Dr. Curran touched a little bit on the formal diagnosis of ADHD and the treatment of that was a dual effect, right? So we had compulsive eating and we had ADHD. So can we pick one medicine that can treat two diagnoses is always best. So working across the team, she had formal evaluation. Oftentimes children with intellectual disability may not even have that evaluated and treated. So by implementing dexmethamphetamine, Vyvanse, and topiramate were some of the medications that helped with ADHD, but also compulsive eating. And those medications, particularly topiramate, can offset some of the medications that Shelley talked about in terms of depression and weight promoting medications. So we were able to do that. And from a medical perspective, we maximized her treatment for her obstructive sleep apnea, which was vitally important. She was connected to her school as Dr. Curran shared. And then we also reassessed and we saw she had some metabolic issues. We added metformin. This was not something that happened day one. This is an ongoing conversation with her mom and her to feel comfortable with laboratory evaluation, monitoring for response. Mom really wanted to prioritize dietary interventions first. So we worked very closely with our dietitian for many, many months, and then reassess and come back and say, well, how did that go? Many of her related comorbidities, including hyperinsulinemia, prediabetes, and hypertriglyceridemia improved, but her obesity did not. It actually worsened. And so we had conversations about the newer medications, GLP-1 agonists. Star is the prior authorization queen of the universe to try to work with insurance companies, but we still ongoingly had denials. So we have a now 17-year-old who has a BMI at the 170th percentile, who's on multiple medications with worsening of her obesity. So we had the conversation about what are all the tools in the toolbox, and that included metabolic bariatric surgery. So that is the open conversation we've had with the family, and it was a journey for sure. The patient had a lot of questions. She said, I need time to think about this. This is great. You should be asking questions. And when you have that consultation, explain to her that you're not going to walk in that door and leave the next day having had surgery. It is a process. There's a protocol. And there's an opportunity to be involved and ask questions, and you all have to feel comfortable with that. So as we stand today, this child, this young adult, is on par to have her metabolic bariatric surgery within the next coming months, and she's excited about it. And I'm going to turn this over to Star for the last little bit of what she said in her words.
We need to kind of jump into some questions. Star, can you answer that quickly, please?
She wanted to share on her journey, never give up.
Awesome. What strength that shows. So
Yes.
Students, thank you so much. Students, if you have questions, please put those in the chat, or feel free to raise your hand or unmute yourself and blurt out your questions, since we have some fairly limited time here.
Dr. O'Hara, one question was about genetics. I don't know if you want to speak to prevention genetics at all.
Sure, absolutely. I think one of the things that was in our story was early onset severe obesity and hyperphagia. So when we see that as clinicians, that should be a red flag to us. So any child with early onset obesity, particularly under the age of 5, with the story of, I've never felt full. I may feed her and within minutes, she's asking for her next meal, sneaking food. That creates more blame. So we did work her up through prevention genetics, which looks for forms of monogenic obesity that is helpful to us, some of which actually have FDA approval for medication. There are 3 that are now available and FDA approved forms of monogenic obesity, and there's ongoing trials to expand that medication to 32 other phenotypes. And when we've gotten phenotypes that are not currently providing a medication indication, our families will share, it helps explain the why, like Star talked about. Why is this so much more of a challenge for this child versus that child or this patient? And when we can show those epigenetic underpinnings and genetic reasons, it really broadens the conversation and importantly takes away that bias and stigma that it's really not your fault.
Really important point.
Excellent.
Thank you. Other questions? Anyone? Quick comment?
Well, I think Rob had a really interesting point from nursing in the chat, and talked about the issues that, when children feel empowered to have some control over what's happening for them, they can feel able to follow through on protocols, etc. I don't know whether Rob wants to unmute or whether you just want to speak to the issues of having the child feel very engaged and in control of what's happening.
So I'm just going to speak quickly about a sense of being out of control. And kids will tell us when they have compulsive eating that they don't feel that they have control. Similarly, kids with attentional dysregulation or emotion dysregulation will say they're on a roller coaster, they're not in charge, and it's just taking them for a ride. And so if we can treat some of these things, and compulsive eating kids will say, oh my gosh, like I can decide when I eat, and when I'm hungry, like that's when I eat, and it's just a few times a day, and it's not all the time anymore. And how amazing is that? That's something that we've witnessed over time. We are always chatting with folks and saying, here are our options. And with kids, what would you like to, what would you like to do next? What would you like to try? Here are some thoughts. What new foods would you like to consider eating? What new activities might you want to do? So there is definitely patient driven, intervention style and all of the things we're talking about today.
Excellent answer. And I think it really highlights the critical nature of behavioral health in this person's healing. So this was really, really good. For additional folks, if you have questions, can you please either put them in the chat now, we'll get them answered, and or you can write those, send those to, say, me in the next week or two, and we'll send those over to our panelists. Quick response we have, let's see, we've got just a few more minutes to sort of wrap this all up in a nutshell. So
Sure.
Dr. O'Hara.
Great. So I think this slide, borrowed from Dr. Anya Yosifov at Yale, is really important. Our key concept is that obesity is a disease. It is heterogeneous. How patients will respond will be variable to different treatments. And as Star said, if the treatment didn't work, it's not the patient that failed. We need to rethink this. And it is complicated. By all the comments from all of you today really illustrates the complexity, and more importantly, that it's chronic. And currently we don't have a cure. This requires ongoing care and management, and really being thoughtful about that and sharing those realistic expectations with our families and patients, which helps to reduce bias and stigma. Star.
Oh, I just wanted to say what it teaches us as far as validating and listening, and let the children as well as the families have an active role. So the more active their role, the better sense that they're going to feel empowered.
And I think too, touching on what we're all here today as interprofessional, maximizing the expertise of your colleagues. Just like our patients not there by themselves, we're not here by ourselves. Can we pick each other's brain? Can we share our experiences? And to me, that really elevates the care that we give our patients, and really highlighting that, sharing our treatment options at the same level of medical data that you would with any other disease. Ask why, like Star said, and explore other options if something isn't working. And explaining that that's typically what happens in the disease of obesity. That is what we know. That's what we've learned. Next slide. So to me, this is a super exciting time. This hour and a half with you has been super exciting, but also thinking about the robust research, whether it's prevention genetics, medication, surgery, psychosocial issues, impacting all of those things. We have an improving number of effective tools. 20 years ago, we didn't have all of the tools that we have right now. Increasing opportunities for training each other and our future providers like we're doing today is, wow, that's super awesome. And I think remembering that when a treatment doesn't work, doesn't improve the disease, the treatment failed, not the patient. We have to put our heads together and come back with the family and our colleagues to do a better job for our patients.
Thank you, everyone, for your contributions to what just kind of flew by this amazing session. I'm really grateful for the time and attention our panelists brought today, and to the UNE faculty members who contributed so much to this session. And to all of you as making this last session for me really special.
Well, Jen, I have to follow that up without getting verklempt. Thank you so much for everything. And this is only the first of many discussions I hope we'll be having in the arena of childhood obesity. And I know Dr. O'Hara and others are committed to keeping this going. So I just want to give you a little clip of what's happening next week. We're going from childhood to older adulthood, and we're going to have Dr. Matthew Fullen here next week, who'll be talking about prioritizing emotional well-being and resilience in the care of older adults, a really critical topic as Maine is the oldest state in the nation, and across the country and across the globe, we have increasing populations of older adults. There are lots of ways to participate in this event. You can join us at UNE North, that is on Forest Avenue. That's where Dr. Fullen will be actually presenting in person. You can always come in by Zoom. That's always our option, Facebook or live stream, to hear more from Dr. Fullen as well. So thank you all for being here today and participating and learning. And thank you especially to Jen and the panel and to the faculty and to our amazing team of Chris Hall and Michelle Cody and Lee Cody for making this a great event. Thank you so much.
Thank you.
Thank you.
Thank you all. It does take a village.